Hello, I'm Eileen Anderson. I'm a medical anthropologist and associate professor of bioethics at Case Western Reserve University School of Medicine. There, I also direct our educational programs in bioethics and medical humanities. Today, I'm talking about how cultural context shapes illness experience. What is culture? It's beliefs and behaviors shared by a social group. Culture impacts every aspect of our lives, whether we think about it or not. For example, in some cultures, we drive on the right side of the road, and in others on the left. In some, we eat with forks, and others chopsticks. Also, how we grow up thinking about illness shapes our experience of illness. I will make 3 main points about dementia from cultural perspectives. 1. Understandings of dementia vary around the world and even within the U.S. These understandings are always linked to cultural notions of what it means to be a person, to be a good person, and what is valued in society. 2. These understandings are central to the ways cultures manage dementia. 3. There are both pros and limitations to any way of understanding dementia. Our typically biomedical approach can benefit from including patients' cultural beliefs and behaviors. Here's what I mean. As we've heard from Drs. Kubu and Lamb, in the United States, we have a biomedical definition of dementia, or what is diagnosed as major neurocognitive disorder. This definition serves as an umbrella term to house a number of specific neurological conditions that Dr. Kubu mentioned. In all of them, the major symptom is the decline in brain function due to physical changes in the brain. In this definition, the root is biological. The problem is situated in the individual and is measured by loss of prior functions. The interventions are targeted toward the individual, including sometimes removing that individual from their previous environment. Meanwhile, biomedical research continues forward, attempting to find more effective drug interventions to slow decline and restore prior function in the individual. As Dr. Lamb demonstrated, situations with dementia in the U.S. tend to elicit strong negative cultural emotions such as grief, fear, and pity. Well, how else might we react? We medical anthropologists often bring up examples from other countries or cultures to show that how a condition is thought about, experienced, and managed can vary significantly. Many brain-related conditions across the lifespan have been studied cross-culturally in the last 40 years. Interestingly, outcomes are not always best in the wealthiest countries or Western countries. Sometimes, poorer and developing countries have better outcomes on average than wealthier countries. Why? Some common themes have been found, such as lower stigma, higher social support and integration, and creative environments involving multiple ways to support people with dementia and other conditions. For example, where I do fieldwork in Belize, Central America, the average lifespan has been lengthening, as in many parts of the world. More people are experiencing dementia. The primary treatment there is still in the family networks, changing roles and expectations for people showing cognitive, emotional, and behavioral differences. Families continuously adapt to the changes, generally with strong nets of extended family who step in to help. As mental and physical abilities decline, emotional relations among family members from different generations take a primary value to continue to hold elders in high regard. For example, one 80-year-old woman began to show signs of dementia, and her niece, who needed a place to stay, moved into a spare room to help care for her. The woman's extended family brought over old photos and mementos to capture as many of her stories on recording as possible, and made sure to cook her all her favorite foods. The smells and tastes delighted her. Her children, grandchildren, and other relatives rotated through, checking on her 1 day per week, so no one person was too burdened, and the woman was well cared for. In another region of the world, Japan is an example of a country with a large aging population and more wealth that has been trying to develop new ways of managing dementia. Dr. Junko Kitanaka has done in-depth research on dementia in Japan and has found 3 major ways to help people think more critically about dementia. First, a neurobiological approach relies on the deep-seated Japanese value of empathy. It asks people without dementia to imagine if their brains worked the same way as those with dementia, how would it feel? This invitation to imagine the perspective of someone with dementia resulted in a connection rather than a separation. Second is a creative psychotherapy approach that tried to access meaning, memory, and emotion for people with dementia in ways other than traditional talk therapy, such as through artwork, pictures, music, or trying to jog memory with a story. This approach generated remarkable insight for patients and for families who gained even more empathy for their loved one. The third approach is an ecological approach that focuses on creating new environments to better include people with dementia. As a controversial and bold example, Dr. Kitanaka describes a series of pop-up cafes in Tokyo called the Restaurant of Order Mistakes. In these brief experiments, all of the restaurant servers had dementia. Therefore, the playful interpretation was that you weren't sure what order you would get. These cafes had hours-long waits for their opening, and families, friends, and employees reported positive results from participating in this environment where people with dementia had valued and meaningful roles. While this is just one colorful example, there are many other ways the built environment can support those with dementia rather than isolate, medicalize, and stigmatize them. We can't take something from one country, just plop it into another and expect it to be effective, since it's connected to lots of other systems. But we can see that there might be a lot of ways to think about people, problems, and solutions, and to find creative ways to improve care. For example, across both the Belizean and Japanese cases, multiple senses, such as smelling a delicious meal or hearing beloved music, were helpful. Having relationships and social roles that focused on what people can do rather than deficits also helped. Even within the United States, we are a nation of diversity. As Dr. Lamb showed, our movies, books, and media about dementia depict a very small segment of who actually experiences it. There are so many different cultural backgrounds within the United States. Surely we have many more experiences of dementia than the individualistic cognitive decline model. Take, for example, the fact that African Americans over the age of 70 have twice the risk of Alzheimer's as white Americans, and Latinos, too, have higher rates of dementia than non-Latino whites. Studies have shown that both groups access formal medical services at much lower rates than whites. The reasons for this disparity in access are many, including cultural beliefs and language barriers. However, studies have also shown that both groups have much stronger informal caregiving networks than non-Latino whites that include family members, friends, and neighbors. Rather than focusing solely on improving access to biomedicine, how might we also support such informal caregiving networks with greater resources? It is important to note that while studies look at groups such as ethnic and racial minorities as a whole, There is significant variation among people in any group that needs understood on a case-by-case basis. One size does not fit all. What can we do? We can expand how we think about personhood, imagine creative resources and interventions, and strengthen informal subcultural practices that can exist alongside biomedicine. We want to hear your stories about cultural beliefs, traditions, and practices in dementia experience to share your story of what helps. Your voice matters. Thank you.